For more than a year, Peter Kircher couldn't walk far without having to rest.
I had slowed myself down to such a snail's pace.
Now,
he walks faster, there's no question.
It's really nice to not have to concentrate so much on picking my legs up and putting them down. It just comes naturally.
The science giving Peter hope. Plus,
functional gains.
Functional gains, right.
We've always heard that time is critical when treating a stroke.
There's hope that there's a chance to take that one step.
Now there's an option for patients who missed their window.
It's slow progress, but it's been tremendous.
What doctors can implant even years after a stroke that offers hope. Welcome to Choices, Hope, and Science. I'm Jessica Lovell. We are joining you from the Dolph C. Simons Jr. Family Broadcast Studio. Brain fog, balance issues, a slow shuffling walk. Peter Kircher struggles with all of it as part of his adult hydrocephalus. But he has seen progress and he is hopeful thanks to this tiny device. The University of Kansas Health System is one of a handful of places in the country where doctors implant an e-shunt. Angie Riccono shows us.
A new lease on life in many ways.
Peter Kircher recently took a walk around a Kansas City park. The sun was shining and he had a nice cup of coffee from a local bakery. The best part? No walker.
I'm more steady on my feet and more willing and able to walk. I have to build up my stamina because I'm used to not. But it's really nice to not have to concentrate so much on picking my legs up and putting them down. It just comes naturally.
Getting to this point has been a journey. Peter and his wife Jackie are from Texas. They actually met decades ago in the Peace Corps. The active couple loves to travel and hike, but Peter began to struggle as he aged.
And the first thing I noticed was his memory.
Memory, yes.
And his primary care doctor noticed his memory, and so that was the first sign.
There were other signs. Peter had a tough time walking, too. The doctor suspected normal pressure hydrocephalus, and a test confirmed that. The good news is Peter can improve his symptoms with surgery, a ventricular peritoneal shunt. It works, but has a high rate of complications, and Peter didn't like the sound of the surgery.
Yeah, besides the infection rate, it just drilling in through your skull. It's just creepy.
And it can clog, so I thought there has to be a better way.
Now researchers are working on a new option. It's smaller and doesn't even require surgery. It's called an e-shunt. It's still in clinical trial.
And they have developed a device that's this big, instead of 3 feet long, that's delivered in a non-surgical way. It's delivered by catheters without incisions.
Go.
Peter travels back to the University of Kansas Health System for evaluations.
I think we should have tremendous optimism.
The couple recently shared how life has changed.
We went to a birthday dinner with long-term friends who've known us for decades. And afterwards they said he really seemed more alert.
That was sweet.
Peter was able to walk further distances inside the airport without taking a break. They are talking about vacations, and the couple may even catch a ball game on a return visit.
That's something that getting there, parking, walking, getting into a stadium, finding a seat, there's a lot of steps there that 6 months ago I would not have wanted to even think about doing with him. And now I think we're going to be able to do it.
Big possibilities. It's nice. And just the feeling of independence should be nice.
We are so happy to be talking with Peter and his wife Jackie today. Thank you so much for joining us. Here in studio with us, we have Dr. Koji Ebersole, Director of Endovascular Neurosurgery. And we have neurologist Dr. Ryan Townley. Gentlemen, good to have you.
Of course. Thank you.
Peter, while this is still investigational, can you give us an example of how this has given you back some type of independence?
Sure. And I think independence is the key word. Recently, I've wanted to go some places in town that Jackie had no interest in going, and previously she would need to drive me and drop me off, whereas now I was able to get on the bus, and that it's a fairly complicated procedure to do all that, and I was able to do that, and Jackie was willing to let me.
Yeah, those little things that we all take for granted. Jackie, how does this really change the dynamic of what you both can do together now?
Well, about a year ago, we moved into a really walkable community, and we had not been able to explore much because Peter couldn't walk very far. So that's like a simple thing is we've walked together to coffee shops and restaurants in the park locally. But even more important, it's allowed us to do things separately. Like Peter said about going on the bus, I was able to go to Tennessee to spend 5 days with my family because I wasn't worried that he was going to fall down while I was gone. So it's helped us both together, and it's helped us independently.
Well, Dr. Townley, so nice to see them getting back to life. But explain, what is adult hydrocephalus?
Yeah, so it's basically a clinical condition that you see on an MRI scan or some sort of imaging scan that shows enlargement of the ventricles in the brain. So the spinal fluid accumulates. From a clinical syndrome standpoint, though, it's kind of the common symptoms of walking difficulties, urinary difficulties, and memory changes.
So how's it diagnosed?
Yeah, so ultimately we have to do certain tests to try to help determine if somebody has this condition, and we do that through lumbar puncture testing, and then we do walking evaluation before and after the lumbar puncture.
Dr. Ebersole, how is adult hydrocephalus currently treated?
So you have to remember, it's a fluid imbalance in the brain. That's why the lumbar puncture that Dr. Townley referred to is so important, because the lumbar puncture allows the doctor to remove cerebrospinal fluid so that the brain can experience how it would operate if it was in a different fluid environment. The problem is the brain will restore that fluid in 24 to 48 hours and the symptoms will come right back. So the treatment is to have that new fluid balance be a permanent change. That requires a surgical procedure called a shunt, which is a tubular system that tracks the fluid from the brain through a mechanical valve and then down to another part of the body, typically the abdomen. So it's continuously draining the fluid off of the brain so that the brain can function better.
So in E-shunt, in comparison, it's similar to a size of a sewing needle. It's very tiny. How might this smaller device impact the patient?
The shunt is a very important tool for neurosurgeons. It's the only validated treatment for controlling hydrocephalus. But it comes with important inconveniences. It's a mechanical tubular drainage system that's 3 feet long, tunneled underneath the skin. I think you can imagine how something like that can be prone to malfunction. It would be much more meaningful if we could achieve the same goal with something much smaller and less inconvenient. And that's what the E-shunt is, a small device that doesn't require a surgery for implantation, and it can achieve the same fluid balance. It's possible the fluid balance it achieves is even better than a shunt because the drainage is more natural, whereas the shunt is more mechanical.
What's the recovery time for this implant?
The procedure doesn't require any incisions, and right now we're performing it under general anesthesia, but it's not obvious that that's a requirement. It's all delivered through catheters. And right now we're watching patients for 24 hours in a very tightly monitored setting like the ICU, but over time, if the clinical trial continues to demonstrate the positive trends that we're hoping to see, it's possible that this becomes an outpatient procedure.
Dr. Townley, what are risk factors for adult hydrocephalus?
Age is the biggest risk factor. The average age of diagnosis is somewhere in the mid-70s, but we see ranges from 50s to 70s usually. There's some studies that suggest a larger head circumference can be a risk factor, so some people might have some hydrocephalus even from birth, but there are times where we'll track down images 10 years ago and somebody had hydrocephalus even back then. But some of the other risk factors, vascular risk factors, so we look at high blood pressure and cholesterol. And then a big one actually that I see in the clinic is sleep apnea.
Dr. Ebersole, we mentioned the health system is one of a handful of centers that participated in the pilot study, now participating in the clinical trial. If someone is watching this and wanted to participate, how do they get screened?
I think the first thing to do is to reach out to your primary care physician and say, I have been noticing over the past year or two that my quality of life is slowly going downhill. I'm not getting around as freely as I would like. I'm having concerns that my mind is not as sharp as I would like it to be, I'm having difficulty with bladder control. Is it possible that these symptoms are connected and that I may have the diagnosis of normal pressure hydrocephalus? That should initiate a workup, because the treatment can be very meaningful for controlling those symptoms and returning independence. If you work with your primary care physician and the workup is continuing to be consistent, then you want to meet a neurosurgeon who can who can treat the condition with the classic ventriculoperitoneal shunt. And if you happen to be close to a center like KU that has access to this advanced technology in the setting of a clinical trial, absolutely, I think you should advocate for yourself and see if you can be involved.
Well, we have some questions from the community about adult hydrocephalus. The first one is from Donna, and it's for Peter. Does your shunt require at-home care?
No, none at all. And it's that simple. It's in, and I don't do anything.
Jackie, Derek wants to know, how did you and Peter choose to pursue the e-shunt?
Well, as soon as one of his doctors sent him for a lumbar puncture, and I saw how well he walked afterwards, the diagnosis of normal pressure hydrocephalus was pretty well confirmed. So then I started looking into the treatment, even before we got back to his doctor. And I didn't like the looks of the traditional shunt. All the potential complications, the failure rates, the clogging, the infection. I thought there has to be a better way. So I just searched online for clinical trials for normal pressure hydrocephalus, which led me to the clinical trial that Kansas was participating in. We're in Austin, Texas, and Kansas City's the closest location. It's a 2-hour flight, so it was a natural fit.
Dr. Townley, Jenny wants to know, if this is left untreated, can adult hydrocephalus cause brain damage?
Yeah, so essentially the ventricles, the spinal fluid as it accumulates, can compress brain tissue, and so you can get worsening of cognitive symptoms, but also the walking symptoms, to where we see more falls, which leads to more complications, which leads to, it's kind of a cyclical problem at that point.
Dr. Ebersole, Eric asks, how long does a clinical trial like this last before the e-shunt might become the standard?
I think it will probably take 1.5 years, possibly 2 years, before they recruit the full complement of patients to complete the clinical trial. And then there will be the evaluation period of the patient's follow-up and their outcomes. And then that data will all be accumulated by the national study team and then submitted to the FDA for evaluation, and the FDA will make an analysis as to whether or not there is a place in the U.S. market for the device like the e-shunt. So far, we're extremely optimistic though, but I would say 2 to 3 years.
Peter, Jackie, this has been such a great discussion. Thank you so much. Doctors, thank you so much for joining us and for your insight today. If you would like to learn more about this trial, the number is right here, 913-588-6191. Now we want to share another hopeful patient story around brain health, this time stroke. Every 40 seconds, someone in the United States has a stroke. It is the leading cause of disability. We all know rehab is important. Now there is a special implant that boosts the power of therapy, even if your stroke took place years ago. Here's Angie Racono.
Let me do this real quick. You are pretty tight today. Now we're gonna stretch back out. There we go, now we're getting there.
Jennifer Milner is back to physical and occupational therapy. Her stroke took place about 5 years ago.
Good, way to work through it.
She had brain cancer. The small stroke was a complication at a very busy time in her life. She was a new mother.
Did some outpatient physical therapy here and there, but didn't see a ton of progress with it, so I just kind of plateaued and just kind of gave up on it ever getting better and just assumed that's how my life was going to be.
Life is starting to change. Jennifer heard about an implant called Vivistim. It's not a new device, but it's being used in a new way. It stimulates the vagus nerve to gently wake up the brain. Patients potentially make more progress in therapy.
What you want to get is a functional movement first, and then multiple repetitions of that functional movement to help make the new connections in the brain.
It's tough work for patients mentally and physically.
How are you feeling?
Good, sore right through there, so that's good.
Jennifer picks up and drops balls. This is something she couldn't do for years. Look closely and you'll notice her therapist activates a stimulator.
Nice.
It's slow progress, but it's been tremendous.
That's what the brain does to learn, is do things over and over.
Jennifer's brain is learning she can do this again.
Now we'll switch directions.
She's rebuilding her muscle memory.
There you go. That worked.
Just the functional changes that I've seen at home, at work, have just been so impressive and so amazing.
Now elbow someone behind you like they're too close to you.
Jennifer isn't just a patient.
Good.
She's also a doctor who often works in the emergency room. She was impressed with the data behind Vivistim. Her occupational therapist is impressed with the potential results.
It's something that allows our patients to see that there's hope, that there's a chance to take that one step, build on it, make another step, and there's really no limits at that point to what the potential is.
Bring it back to the table.
Every patient is different.
That's gotten a lot better over the last couple weeks.
For Jennifer, the small gains have been incredible.
Huge. Even silly little things like when I cook dinner at night, being able to hold the handle of the skillet so it doesn't spin in circles when I'm trying to mix everything in it is just huge. Being able to put a diaper on my 1-year-old is huge. I mean, just the small things turn out to be big things.
Dr. Jennifer Milner is joining us from her home today in Wamego, Kansas. Thank you for sharing your story with us.
Thank you.
In studio, we have neurointerventional surgeon Dr. Michael Abraham, Dr. Sandra Billinger, the Vice Chair for Stroke Translational Research, and neurosurgeon Dr. Christopher Miller. Welcome to all of you.
Thank you.
Dr. Milner, how did you hear about Vivistim?
My physical med and rehab doctor, I asked him what was new in rehab for strokes, and he mentioned Vivistim, so I looked into it.
As a doctor, you have the medical knowledge to do more intense research. How did you make the choice to get the implant?
I looked at the studies, I talked to my doctors, and I just thought it was pretty sound evidence, sound studies, so decided to proceed with it.
Dr. Abraham, does the type of stroke impact the success rate for Vivistim?
Yes and no. So technically it is approved for what we call ischemic stroke, where people have a blockage in blood flow to a certain part of the brain. As opposed to hemorrhagic stroke, where people have a rupture of an artery in the brain causes that. So it is approved for ischemic stroke, and as Dr. Milner has shown with her research into this, showed improved outcomes with people with weakness in their arm. But there are some of us who do feel that it could still apply to hemorrhagic stroke as well.
So the implant itself is pretty well known, but this is what the FDA calls a new use. So what is the device normally used for?
So going back to when I was a medical student over 20 years ago, doing my child neurology rotation at Children's Mercy, we've been using this for people with epilepsy or seizures. Very similar type of implant where people, if they feel have a seizure coming on, they could stop it. But now with the addition of this to stroke rehab, we've also seen great improvements.
Dr. Miller, where is the device planted for stroke patients?
So there's 2 locations where any person who got implanted would notice the device. It's always on the left side, just because of the nature of the vagus nerve and what it attaches to in the rest of the body. But there's a battery that goes into the chest, and then there's an incision made across the neck that also is where we go and find the actual vagus nerve. And then we put the coils themselves as far as the actual coils that go around the vagus nerve to do the stimulation.
How long is this procedure? How complicated is it?
The procedure takes about an hour or so, depending on how easily we find the nerve. And honestly, the part we always talk about is just getting the coils nicely around the vagus nerve, because that can be a little tricky. But in all honesty, it's not the most complicated thing we do. It's nice in that sense that it can provide a good benefit without having a significant amount of risk involved. And as we've talked about already, it's a new use for the device, but it's a device that most all neurosurgeons are very familiar with through their training, because we put in a number of these for epilepsy.
Dr. Billinger, where do patients come from and how are they identified as potential candidates for the device?
Yeah, we've had patients come from all over, actually. Kansas City Metro, Lawrence, even in, I've heard from Iowa, we've had somebody come in. So there's a lot of interest in this, and people are talking to their physical or occupational therapists. There's people who are talking to their physicians, maybe if they're going in and getting Botox, which is an injection that helps their hand move. They're having those conversations, and actually 5 minutes before I came over, I had somebody also reach out to me about how to get it. So there's a lot of excitement around this.
So how does the device enhance physical therapy with stroke patients like Dr. Milner?
Yeah. So as you heard earlier in the video, again, we have that implant on the vagus nerve, and that's kind of waking up the brain and stimulating certain areas, but it's really important to be paired with functional activities such as reaching for things and grasping. And when they use that at home, they're encouraged to use it with functional tasks such as maybe, not just picking up balls, but maybe picking up forks or picking up plates or putting them into the dishwasher or taking them out. So when you pair that with activities that you do at home that has some meaning to it, and that really helps it really kind of solidify those new movements and everything.
Dr. Milner, it sounds like the real work then begins after the implant when you're working with your physical therapist. How often do you do therapy?
In-house therapy, we did 3 times a week for the first 18 sessions, and now we do it twice a week. And then I do exercises at home 3-4 times a day for 30 minutes each. So,
what would you say is the biggest change that you've noticed?
I think just like the ability to help out at home with my kids, do things that I couldn't do with them before, pick them up even. I couldn't pick up my 15-month-old independently without having my husband help me move him, and now I can, so.
That must have been an amazing feeling. Do you recall how long it took before you started making that real progress?
So objectively, we did the test at 6 weeks after we started physical therapy, and that was when we first saw any objective gains. I definitely started to see some changes in my life, more subjective changes, around 2 weeks after I started physical therapy.
Dr. Abraham, how much progress can patients make? Do you expect them to regain full function at some point?
Everybody's different, but the big thing we know is that we look at patients who are at least 6 months out from their stroke, but really there's no upper limit. We've seen patients several years out from their stroke, which I think is the important part of it. So, but again, everybody's different on how much they will improve or progress.
Dr. Billinger, we're the only hospital in the region to offer this currently. How big is the demand?
We have had 20 patients in the first quarter, and that's really amazing. And thanks to the team here today and those all involved, but we're the fastest, we are the group that's had the most procedures done in the first quarter. So we've had 20.
And coming from quite afar, as you mentioned earlier.
Yes, so there's a huge demand for it. I think, again, that giving of hope and just the ideas that there's something that can help people with their stroke recovery and even make progress years after is really exciting and motivating for people. Yeah.
Dr. Miller, are there any physical barriers to this implant? People who aren't good candidates because of their anatomy or stroke severity, perhaps?
Typically, as far as anatomy, no. Everybody has the vagus nerve on that side, and everybody has the basic components that they need in order to have the implant put in. That being said, the people that do the best are people who we are able to focus on something very functional, like Dr. Milner, and that making a grasp stronger or releasing a grasp, which improves functionality quite a bit with a small change in actual movement. So patients who have absolutely no movement in their hand or are completely paralyzed in that limb may not be ideal candidates, but at the same time, if there's some minimal function whatsoever, that's something that we can build on a lot with this device.
Well, here are the top questions that we get from the community about Vivistim. Leslie asked Dr. Miller, what makes Dr. Milner a good candidate for this?
She had sort of some function in the hand. It was just very limited to the point where, something very much to build on. On top of that, Dr. Milner is very motivated, which is also very important. She mentioned how intensive the physical therapy is initially, and then even after that, at home and continuing other physical therapy is all how you continue to build and grow.
Josh has a question for Dr. Abraham. Does it matter which side of the brain the stroke happens on?
Not necessarily, but if the stroke occurs on the side where language is at, that could impair the patient being able to interact with the occupational therapist to actually do the maneuvers and physical therapy.
Lauren has a question for Dr. Billinger. Are there any other current research studies regarding stroke outcomes that give you hope?
Well, there's two. So the first one I would say is that people who are getting the Vivistim implant, they are eligible to be in our GRASP registry, which we follow them long term, and this helps us understand how people recover even after having the implant 2 years and 3 years post. So that's really exciting, so we can better understand that. And then second is high intensity interval training, really doing, again, it's high repetition walking activities or exercise that helps people improve their walking and their overall health.
Becca asked Dr. Milner, has the device helped with your work as a doctor?
Oh gosh, yeah. There are procedures that I wasn't super confident in since my stroke that I feel a lot more confident doing now. I have procedures that I still won't do since my stroke, but I'm optimistic that someday I'll be able to do those again as well.
Well, I want to wrap up with some final thoughts from our guests. And Dr. Milner, I want to start with you.
I'm just thankful and grateful for the opportunity to move past my plateau and my weakness with the stroke. And I'm thankful for KU for giving me a chance, and for my team here at work for giving me time off to do physical therapy and occupational therapy. And then, of course, always grateful for family and friends for helping me with all of this too.
Dr. Abraham.
In my 12 plus years of doing this and seeing stroke patients, I feel this is the first thing that we have that has shown a positive impact on stroke survivors.
Dr. Billinger.
Yeah, my message would be not to give up hope. Even with the device, it takes a lot of work, a lot of therapy.
Great message. Dr. Miller, final thoughts.
We've thought for a while that after a stroke things are kind of what they are, but having the opportunity for patients to get better afterwards is a really big deal, and it's really exciting to be a part of that.
Well, I have really enjoyed this entire half-hour conversation, and I just want to thank all of our guests for joining us today. If you have enjoyed our program, Choices, Hope, and Science, I invite you to join the conversation every weekday morning at 8 a.m. on Facebook and on YouTube as we live stream the Morning Medical Update featuring patient stories with the specialists making a difference. So thank you again to our guests, and thank you for watching. Coming up on the next Choices, Hope, and Science.
Most people don't even realize I have any kind of lung condition. And most of the time I don't realize it either.
Some of the results that we see can't be quantified. They are just quality of life.
And the changes in their life is just beyond remarkable. It feels miraculous.
Hello. I'm Dr. Sarah Hahn, Vice President of Neurosciences at the University of Kansas Health System. We have the largest and most subspecialized neurosciences care team in the region. Our program provides proactive care to help patients attain and maintain brain health. To learn more about our neurological care program, visit kansashealthsystem.com/neuro.